Welcome to Advanced Nurses. We connect with nurses who inspire other nurses by sharing their experiences. And so we're able to bring that information to you.
We have an awesome presentation addressing common misconceptions about clinical documentation integrity and how nurses can overcome barriers to become health information management professionals.
Hi, I'm the educational consultant with Advanced Nurses at ACD4N, and I'm here with the coding nurse, my favorite. So, could you please just let us know what you have been up to and what we can look forward to getting from you like this year? And you can just start.
All right, so thank you for this invitation, Raquel. My name is Jesse. I have been in HIM for over 10 years. I left the bedside. I'm an LPN. I left the bedside in 2014. Well, actually 2007. In 2014, I transitioned into my first HIM role, which was a risk adjustment auditor. So after that, I just fell in love with the revenue cycle, wanted to learn more and more, which led me to other opportunities. So most recently, I worked in CDI, and I am currently working on. Oh, and in 2020, I created the Coding Nurse, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM, like I did. So currently, what I'm doing is I have two classes currently, ICD-10 CM classes. One is Tuesday, Thursday. One is Monday, Wednesday. My next class starts on, I think it's Thursday, March 18th. And what I'm going to offer this year is I'm going to expand my services to coaching people, nurses who are already in CDI who don't understand coding quite yet. So I do have one client currently that I'm coaching. So I'm looking to expand and get more and more nurses who are already in CDI but just need to really understand the full implications of how coding can impact their jobs.
Wow, that is awesome. You know, one of the reasons why I'm always so excited to talk to the coding nurse is because the coding nurse actually helped me to broaden my experience as a nurse, my exposure to CDI, my exposure to HIM, and really promoted that kind of nursing excellence that I think oftentimes we hear within the profession. We hear it when we're in school, but it's not, I think, often actualized for most nurses because we just don't know the pathway. I think what you're doing is awesome, especially what you just said about nurses who are in HIM, because when it comes down to it, a lot of nurses are kind of feeling their way in the dark in HIM because it is a new territory. A lot of times your HIM team members, these are the individuals coming out and speaking to you on the units about certain aspects or changes that may happen within the EHR. So many nurses who are informaticists may actually interact with the HIM professionals on a regular basis, and maybe some other nurses who are more on the front line may not as often. But these are individuals who we should be collaborating with. We should be learning from them. But again, when you're stepping into CDI, because it's such, uncharted territory, there's so many dark spots. Many of us really don't know what to do when we come into that space. So that's really where this conversation is going to today. We're going to be talking about some misconceptions, but we're also going to be, bringing some clarity where we think it's needed. So I'm just going to begin by just defining what clinical documentation is. So clinical documentation integrity, and this is from AHIMA. AHIMA essentially defines CDI as a process of ensuring that health records are accurate, complete, and reflective of patients' clinical status. This involves reviewing and improving documentation to support accurate coding, quality reporting, reimbursement, and patient care decisions. So without accurate, clear, concise, reliable clinical documentation, you can see how many areas within the healthcare system can be impacted. And I say that because clinical professionals oftentimes are really caught up in the diagnosing and treating aspect of the work. And to a certain degree, we may write things down or work with patients and not really think about what happens after the documentation is entered into the system or entered into the health record. And so therefore we miss all of these opportunities to learn from our HIM professionals. So again, so many areas impacted: finance department, operation, data analytics,
Quality.
quality, compliance, so many different aspects. So HIM does sit in 3 different houses, and we'll talk about that a little bit in the next slide. HIM, case management, and quality, the quality department. So when we're thinking about it from the perspective of HIM, we're looking at ensuring that there's accurate documentation for coding, accuracy, regulatory compliance by auditing records, resolving discrepancies in the medical record, and training clinicians on documentation standards. And that we're gonna really talk a lot about that aspect. And then there's case management. Strengthen CDI by validating clinical details to support care transitions, justify medical necessity, and optimize reimbursement. For many nurses, this is probably the best point of entry because of the fact that you are able to lend your clinical expertise and care coordination to this process. And I think that this is a great way for you to see how everybody is collaborating. Sometimes in nursing in particular, we can work in silos, but I find that in case management is impossible to be in that work in that silo. And so it puts you in a great position to really understand the impact that you can have in CDI. Also, quality department. Within the quality department, what CDI is able to do is to drive accurate quality metrics, influence risk adjustment, not only the data collected in risk adjustment, but all of the activities involved in collecting risk adjustment data from our patients. Compliance and regulatory reporting, improving patient outcomes and institutional performance. So we're going to be talking about some misconceptions. And the reason why we want to talk about these misconceptions is because, again, if you really don't understand the role of your HIM professional and you really don't understand and appreciate the impact of clinical documentation integrity, oftentimes as providers, as nurses, as even students, so you may have providers who are in training, you really don't appreciate or really get a full understanding of how clinical documentation influences everything. So some of the misconceptions we want to talk about, we'll go into misconceptions around certifications, misconceptions around your experience that you need to get into CDI, and also what CDI really can do to improve your practice altogether. All right, so misconception number 1, CDI is only about coding. Jesse, you can explain it or go into this one a little further.
Okay, so CDI is so much more than just improving coding accuracy, because we know ultimately that coding is based off of documentation, but CDI is there to clarify documentation, and CDI is also there to make sure that there is clinical support for the documentation. And that's where the clinical piece of nurses comes into play in CDI. Like there are clinical indicators that have to be present to support this condition. And is this condition documented completely, accurately, and to the highest level of specificity in the documentation? So if all that is done by CDI, then, by deduction, the coding accuracy is going to improve because the clinical documentation has improved to help improve the coding accuracy. But it's more to it than just coding. You have to have the documentation and the clinical support to support the coding.
And with that, I just want to echo, because we had a conversation prior to this talk today, And that also speaks into the importance of policy, right?
Yeah.
And I know that's
Oh,
something that's very
absolutely.
important for you, because when you think CDI is just really about coding, what you really do is, first of all, and I hate to say it this way, but it really is a disservice to the coders too,
Yeah.
because essentially it minimizes the fact that you have coders with specialized knowledge, and even what they do oftentimes is misunderstood and misrepresented, especially with the lack of process and policy and real support and training in a lot of these places where they have to work. And then also, when it comes to CDI, if you think about it, it's just about coding. Then what do we say about, and we'll talk about this a little bit more later, about nurses who go into CDI roles and they're great, given this awesome opportunity, but they don't really know anything about coding. So we know that CDI is definitely more than about coding, because so many nurses go into CDI without a coding background, right?
Right. Oh, most.
Exactly. So we know it's more than just about coding. Misconception number two: CDI professionals do not need to know coding. I just mentioned that, but Jesse, I'm going to let you elaborate on this one.
I think that any person who wants to go into CDI who does not know coding is trying to, and my I can just equate it to, and I'll make the analogy. You're getting into a boxing ring with one hand tied behind your back. Like you're not even fully armed or capable of doing your job. Like there's no way you can do your job as a CDI professional accurately or even at all, honestly, without knowing medical coding. And if I could, I'll just give a couple of examples. Like
Sure.
because the entire role of CDI, what is supposed to happen in a perfect world, is CDI will look at a patient and follow a patient from admission through discharge. Once the person is discharged, then the case goes to coding. That's the first time coding looks at it, is once the person is discharged. So in the real world, by the time that case makes it to final coding and discharge, it is supposed to be complete. There should be no query opportunities, and any query opportunities should have already been addressed and settled before it even gets to the coder. Now, that does not happen because a lot of times nurses do not know coding, and your job as CDI is to assign a working DRG. And a working DRG is based off of ICD-10 CM and possibly ICD-10 PCS codes if a procedure is performed. If you do not know how to code what is there clinically, how can you assign an accurate DRG? Then what happens is if you assign an inaccurate DRG because you don't know coding, when it goes to coding and coding gets a different DRG, it is called a DRG mismatch. Then coding has to contact CDI to let CDI know that we have a discrepancy and this is why. So it slows up the back end, and it's a lot of back and forth that could really be prevented if CDI knew coding as much as they have a clinical background. If they knew ICD-10 CM and ICD-10 PCS, by the time that case is moved through discharge, because you could have a case. I mean, I've had cases that were inpatient for like 50 days. So 50 days of following a person, there should be nothing left. Like it should be cut and dry. Even if it's 3 days, it should be cut and dry because you should know coding. You should know, well, based on this clinical information, would be the principal diagnosis, and based off of this principal diagnosis, this could be the DRG, or this DRG could be increased because this condition is a CC or an MCC, or if this person goes to surgery and has a particular operation, this operation is going to then make this case, flip this case from a medical case to a surgical case, and you'll get a different DRG. Like for instance, I'll let us go on after this, but I have an example. The most One of the most common conditions in hospitals is sepsis. So if someone has sepsis and they have a procedure, that procedure is going to make the case go from a medical case to a surgical case. So like let's just say somebody comes in, they have met sepsis or SIRS criteria, like they have um, an elevated WBC greater than 12. They have their heart rate is above 90, and let's just say their respirations are above 20. Those are the clinical indicators for sepsis. Plus, they have an infection. Let's just say they had appendicitis, and they have their appendix removed. That appendectomy is a surgical procedure, so it will flip the case from, if they, let's just say they had like a CC or an MCC, so that would make it an 871, a DRG 871. If they have a surgical procedure, which is the appendectomy, then it goes from an 871 to an 853, which is a considerable increase in money or revenue for the hospital. But if the CDI doesn't know how to code ICD-10 PCS procedures, it's going to go to coding as an 871. Coding has to contact CDI and say, well, there's a procedure you didn't code, so now the DRG is 853. So that is the importance of knowing coding as a CDI professional.
Misconception number 3, CDI is a one-time effort. So about this misconception, clinical documentation integrity is a one-time project that can be completed and forgotten. Now, before you go, because I definitely want to hear what you have to say about this, the reality is that CDI is an ongoing process that requires continuous review, education, and collaboration among healthcare providers to maintain high standards of documentation. If you approach CDI with this mindset, you would probably think it would be acceptable to have a very small HIM department where you're asking them to do everything, not only from an administrative standpoint, but in a very supportive standpoint as well. So that this individual is not necessarily really leading anything, because CDI is about processes. So like every process, you have iterations, you have improvements, you test things, you look at what's working, you measure things, you have analytics. So with everything I just mentioned, how could that possibly be a misconception? How could there possibly be a misunderstanding that CDI is a one-time effort when you need processes? Can you tell me how do we get to this place with this misconception?
I think that, and you had mentioned a word earlier in the presentation, siloed. And I think that there are people who think that there are aspects of HIM that are siloed, and it's not. And it's no one and done. It's like, it is a process. Like you said, it's a process. You need policies, and you have to track those policies and those processes over time to make sure that it is functioning like a well-oiled machine. And I have an example, like as a CDI, like you follow the person from admission to discharge. And we know as nurses, we know that we're trained that the discharge process begins on admission. So if you're following a patient, and this goes to how, you had mentioned case management. So I have had patients who, because you have to read all of the notes, because there's so many people that see a patient while they're in the hospital, and case management is involved. And let's just say, like, I've had patients who were not able, who were lived independently, but because of their current state of health, they're not ready to go back home, and they may or may not have a support system. And they may not even have the cognition to make an independent decision. And so case management is involved with trying to find someone who can be responsible. I've had people, I had a patient who was in the hospital for an additional month because they had to establish guardianship. And the nearest person they could find was in a whole nother country. So during that time that that person is in house, you still have to monitor them. And this person ended up developing a hospital acquired condition, which further delayed, their discharge. But that's the whole collaboration. How it's not a one time process that can be forgotten, because now, in addition to CDI being involved in this particular case, then risk management gets involved, because then they're like, well, what could they have done, or what can be done in the future if you have a case like that? Do you want to identify next of kins earlier? Do you want to have, find out, what support system somebody has earlier, so if this happens, you can move quicker. So that's why it's not a one-time process.
Thank you. Misconception number 4: CDI is only the responsibility of CDI specialists. Now, you just spoke about collaboration, so we know that this misconception is rooted in a lot of misunderstandings. Again, like I mentioned before, about the true role and responsibility of HIM professionals. CDI is the sole responsibility of CDI specialists and doesn't involve other healthcare professionals. This misconception, we know that this can't work. Because essentially what that does, it goes back to that silo thing as well, where you have someone working in their own little corner, in their own little department, and you're saying, well, that's just for them to worry about. So then you have providers that look at CDI professionals and really don't know what they're doing, what the role and responsibilities of those professionals. But at the same time, there are things that they don't want to be involved with, and they'll just push it off. You know, I've seen myself where providers actually think that the CDI's role is to tell them if there's something missing in their documentation, not educate, but just tell them, like someone, I guess, telling you that you have food in your teeth. So we know that that's not what CDI is about. The type of collaboration CDI is really calling providers, other members of the healthcare team as well, is to work along with CDI professionals in ways where you are not only getting a better understanding of being the true owner of your documentation, but like you said, understanding the patient situation more. Because I could tell you a nurse is not going to be concerned with the provider's documentation. It's the provider's documentation. But like you mentioned earlier, nurse may be concerned with those other clinical indicators that can guide the provider to more specific documentation, which is going to lead to that specific coding. So missing those red flags and those little signs, that's something that the nurse can do, but the nurse doesn't do that by themselves. So therefore, why would we say that CDI is something that it's just something that, oh, just let them do it. Let the CDI people handle that. And further, again, create more silos where we don't need those barriers. We don't need those silos. They don't help anyone. So what's your thoughts on that?
So, like we have established or are establishing, CDI is a collaboration amongst all kinds of departments. And it's not that, and like you said, it's not CDI's responsibility to tell the provider that something is missing. It Part of the role is to educate. So hopefully through bringing these things, these situations and these instances to a provider's attention over time, they will begin to improve their documentation. And for instance, I had a case where the nurse, during her assessment, had found that the patient had they said it was a stage 3 pressure ulcer. Well, they said it was a pressure ulcer. They said it was a stage 3. So what was interesting was in the HMP, it was no provider had documented that this person had a stage 3 at all. And a stage 3, if it's not present on admission, is considered a HAC, or a hospital acquired condition. And the hospital will really get dinged on all kinds of quality measures, because that means that this person is not being cared for adequately. They're not being turned or repositioned in a timely manner. They may not be receiving adequate protein and nutrition. So it affects a lot of different departments. So because this nurse had the wherewithal to document that this person had an ulcer, then I had to send a query because, of course, since the provider did not document it, then the provider did not order any kind of wound care because they didn't see it or they didn't document it. So because there was this nurse actually saved the facility from a hack and also improved patient outcomes because then I, as the CDI, I have to send a query to the provider to see if they agree with the findings of this nurse and also supply the documentation. So once the provider agreed and documented that this person did have a stage 3 ulcer, then ordered additional treatment, that person received the care that they should be receiving, and they also saved the hospital from a hospital acquired condition and a ding on their quality measures.
From our collaboration.
Yep.
Okay. Perfect. Misconception number 5: CDI doesn't impact patient care. You just spoke on that.
Yeah.
I'm not even going to have you elaborate on it because we have some slides coming up that I really want to hear from you on that. But The truth is that, as you mentioned before, clinical documentation integrity has huge impact on patient care and patient outcome. And it's not just an administrative role and responsibilities. Once you minimize CDI to just administrative work, what you essentially do is you take that expert, that SME, and you minimize them to no more than someone, again, just telling somebody, hey, do this, and little reminders. By the time you know it, you have departments that are just down to a skeleton because the company, the organization, the healthcare system doesn't see the true value of what CDI can really do for them. So we know that CDI plays a huge role in patient outcome and also the impact on patient care. The reality, again, is that through this documentation, there is a huge impact in patient care. Because when this documentation is complete and accurate, it paints a clear picture of the patient's health status.
Absolutely.
And leads to better support for that patient, better decision-making, better continuity of care, inpatient and outpatient.
So CDI doesn't impact patient care. We know that in CDI, especially inpatient, we have two prospective payment systems. We have the MSDRGs and the APRDRGs. So everybody is assigned both, even though you only need one for their payment, depending on what insurance they have. But almost everybody is assigned both APRDRG and an MSDRG. But APRDRGs are really, really important for quality because, for instance, when someone expires, anybody who is not, because in the APRDRGs we have two components. We have the SOI, which is severity of illness, and the risk of mortality. So the highest level is 4, which is extreme, and you have to have a score for SOI and a score for ROM. So if a patient, at least where I worked, if a patient expired and their SOI and ROM was 4/4, it did not go to the mortality review committee. If a person expires and they are less than 4/4, that patient's record goes to the mortality review committee, and the review committee encompasses nurses, doctors, and CDI and case management. And they review this case because sometimes what can happen is there may have been a query opportunity that was missed by CDI to get it to a 4/4, or you look at the record and because they want to examine this case to make sure that there was no gap in care, to make sure that they did not drop the ball that led to this patient's demise. And so in CDI, when you are following a patient and they expire, you always give that case like a thorough review from beginning to end to make sure that you didn't miss any opportunities. And I know I've had patients that have expired and they weren't quite at 4/4, but when I reviewed the record, I could see where, okay, well, this could be a potential for me to query the provider based on the clinical information. And sometimes I have had the provider come back and they would agree with the query and document a condition that would get the person to 4/4, and then sometimes it just doesn't. But that clinical indicator or that quality review also, with the mortality, because we talked about quality, but we didn't talk about mortality. And that's how CDI impacts patient care. And then also I had done a review where the ventilator time, because ventilators are based on continuous time, like not start and stop, but continuous time on a ventilator. And I had done a mortality review, and the ventilator time was not accurately updated, so it resulted in a higher code. So that's how CDI impacts patient care.
Love when you tell those stories. Now, I do want you to speak about financial benefit, if you don't mind.
Okay.
Mm-hmm.
So, um, every query that you send, if it results in, just like, um, if I send a query to get a case, like for instance, if someone comes in to the hospital and they are like a known hypertensive, they're a known chronic heart failure person, but um, they're in because they have like shortness of breath, pedal edema, and let's just say they have a really high BMP. So those are all clinical indicators for an exacerbation of heart failure. So they might have, let's say, based on their echo, they have an ejection fraction of like 40. So that would be indicative of systolic. So let's just say they have chronic systolic heart failure, but based on the clinical indicators I just mentioned, that would be a potential for acute on chronic systolic. So um, I would send a query to the provider, and that, let's just say the provider only documented, or the attending only documented, chronic systolic heart failure, but they did not say that this person had um, acute on chronic systolic. So that would be like a 292 MSDRG. So if if it goes from currently chronic, and then I send the query and the provider says, well, yes, this person does have acute on chronic systolic heart failure, then it goes to a 292. So that difference in DRG price from 292 to 291 is called financial impact. And in CDI, they track your financial impact. Like, they track the financial impacts of your queries. That's why queries are so important. And they analyze queries. They track them in 3M, and they can tell the difference in whether the query like increased the DRG or whether it stayed the same. And they can calculate the financial impact that you have made based off of your queries. And financial impact means how much did you increase the hospital's potential revenue. And I've been in meetings where, like, in a month, um, CDI has impacted or increased a hospital's revenue by like $700,000 in just 1 month.
So let's address some of these misconceptions. While we did speak on a lot of this, just want to go through a high level kind of review of addressing some of them. So, first of all, when it comes to CDI, the misconception of CDI is all about coding. It is important to emphasize that CDI ensures comprehensive documentation that supports patient care, compliance, and accurate coding, which again is the reason why you have to have policy and procedure related to CDI. You have to. Not only because of the impact of CDI, but also the inner working of that coding piece, what that coder is doing. It requires very clear, processes. You need a process for escalation. You need a process for where information should be stored, where it should not be stored. You need a process for the different functions of everybody on the team. Where does the department sit? Do they sit in compliance? Do they sit in finance? Do they sit in quality? Okay, so again, CDI is far more than just coding. Also, CDI professional. Oh, would you like to add something?
No, I just said absolutely.
CDI professionals do not need to know coding. Okay, so CDI as a liaison. CDI requires a collaboration of clinical documentation and coding to be effective. So all CDI professionals need to know coding. CDI is a one-time effort. It is important to promote continuous improvement. Establish CDI as an ongoing process that involves regular reviews, updates, and staff education. CDI professionals are really focused on education and training, again, so that provider is the true owner of that documentation. Because in an ideal world, the education provided to a provider would empower that provider to write with more specificity or clarity. For example, you wouldn't have medical records where you have 4 or 5 different heart failures in a given year, because then the question would be, is that provider really paying attention to that patient's record? Is that provider really taking care of that patient? More importantly, if there's so many different indicators or so many different diagnosis in that medical record, and we really haven't pulled it all together to say that this patient now has this particular condition or no longer has that condition, and again, what kind of care are we providing for that patient if we're not clear about the diagnosis? Because essentially, these are the kind of questions that CMS asks, right? And different payers ask. They want to know, wait a second, are we paying for something and the provider hasn't even given us the documentation to support the medical necessity? So this is where a lot of places can get in trouble. And maybe they may ride high because they're getting away with little few things here and there. But God forbid, if there's ever ever a time or opportunity where a payer says, hey, you know what, we're not paying for any of these type of services anymore because, maybe we got in trouble, when we try to submit this information, let's say to CMS, for example, especially when we're talking about like risk adjustment models, these are the kind of times where I feel like a lot of these places kind of got caught, with their pants down, so to speak, because it's like, okay, well, what were you doing to prevent these denials or prevent these problems from happening? But if you're thinking again, as your CDI individuals are just there, their CDI professionals are just there to kind of help push things along, you're not really thinking, okay, well, let's have processes in place. Let's have some checks and balances and have a system where we can kind of go back and see what's working and what's not working, instead of just having it as a stagnant, static process that now that we build a building, we could just walk away, and that doesn't work anywhere. And it definitely doesn't work in CDI. It doesn't work anywhere in healthcare, actually.
And then another, I did want to just jump in on misconception number 3 is, we also, like, we talk about denials all the time, but what a lot of people don't talk about is also there's another measure that CMS and a lot of payers pay attention to, is someone's 30-day readmission rate for the same condition. So that is where continuous improvement can come in, and that's where it's an all hands on deck type of thing, because like, did this person receive the appropriate supportive transitional care? Did they have home care set up when they got home so they'll be able to monitor their blood sugar or whatever kind of gap needed to be identified, so they wouldn't have to come back to the hospital within 30 days? Because if you're readmitted within 30 days for the same condition, you can suffer a deduction in your recoupment.
Thank you. Just in case those who didn't hear that, there you go. There's another way that financial impact comes into play.
Mhm.
Not just financial, but more importantly, quality, right?
Yes.
So, misconception number 4, CDI is only the responsibility of CDI specialists. So, it's more important to foster a collaborative approach. Engage all healthcare professionals and CDI efforts. Make it a collective responsibility across the organization. Also, addressing misconception 5, CDI doesn't impact patient care. We all know that this is not true at all, or everything that we've said before here, but we know that this is not true. So connect CDI to patient outcomes. This is something that CDI professionals can do as a way to show their value, but more importantly, this should be coming from your executive line. Okay, those who are holding positions and leadership roles really should be promoting enhancing the understanding and the connection between CDI and patient outcomes. And then also addressing misconceptions. 6, CDI is primarily about financial benefits. While there may be a lot of discussion about the financial impact that CDI can make, it's not just about the financial impact just in dollars, but also in fines and penalties. So it's not just about making money, it's also about preventing fines. That's
Yes.
a financial impact. Okay.
Yes.
So, and it's important to highlight that the primary goal of CDI is to ensure high quality, accurate documentation that supports patient care and regulatory compliance. So, this is the misconception I saved for last, along with some real special ways to address this issue. Now, I want you to address these, and I'll just kind of add my 2 cents in, but I'll let you have the mic for this one.
Okay. So only RNs can be CDI specialists. When you look on Indeed or LinkedIn, you would think that that was the case because the overwhelming majority of positions that are listed require an RN license. And I think that, and like I said from the very beginning of this discussion, I'm an LPN. And I would think that by now, anybody who has listened could really tell that I know what I'm talking about. So, how they can just make a blanket statement that only an RN, and I understand why, because you do need a clinical background is extremely helpful, and especially an acute care clinical background. And also, I've been an LPN long enough that I came along in a time when LPNs were allowed to work in a hospital, and I did work in a hospital. That's several across multiple states. So I think that a clinical background is necessary, but it's not the only path of entry because if you are an RN, like I just mentioned, knowing coding, like just to make a blanket statement saying you have to be an RN to go into CDI, how are you ever going to learn how to properly assign a DRG if you do not take the time to learn coding? And most people in CDI come into CDI with a deficit because very few nurses go into CDI as certified coders. If you the sweet spot is to go into CDI as a clinical person with a coding credential and coding experience. That's the sweet spot because the learning curve for CDI is extremely steep. I just cannot imagine if I had not have had at the time I think 8 years of coding experience along with my clinical background when I went into CDI, the learning curve wasn't as steep for me, although I still had to learn a lot because even though you work inpatient, you don't see every condition. You don't know every nuance of every condition, but you have enough of a clinical background to lead you to look at the proper resources to make adequate clinical decisions about the care that you are reading this patient is receiving. So if you are an RN, you come in not knowing coding. If you are an RHIA or RHIT, you come into CDI not having a clinical perspective. Can you learn clinical indicators? Absolutely. Just like a nurse can learn coding, a coding professional can learn clinical indicators, because that's why you have all of these um, toolkits, you have all of these online resources like Actis and uh, Pinson and Tang have have pocket CDI resource guides. I mean, I'll get a CDI pocket guide every other year just to stay abreast. If it's a condition I'm not sure about, I'll just flip to it and look up what the clinical indicators are, what the possible query opportunities are. All the information is right there. So everybody, the overwhelming majority of people come into CDI with some kind of deficit. So to just make a blanket statement and say that only RNs and MDs and PAs can work in CDI is, you're just shooting yourself in the foot, and you're missing out on a whole lot of talent.
Very good. Thank you. Also, one credential guarantees success in CDI.
Absolutely not. Because CDI requires a very broad approach. So in addition to, for instance, if you are a nurse, because since we're both nurses, if you're a nurse and you get a CDI, if you get a coding credential, that is fine. But a coding credential is not going to teach you the deep nuances that you need for coding, for querying, because it touches on the need to query and why you were querying and the types of queries, but it doesn't really drill down into, because when you work in CDI, you have to write very, very specific, very detailed, compliant, clinically based queries, and it takes time. So in addition to having a coding credential, it is also helpful and beneficial to get a CDI credential, because that gives you the the expertise in the whole CDI cycle, how CDI is important, why it's important, all of the different stakeholders in CDI, and how you can see how it gets into metrics, why metrics are important, how metrics are tracked, and how, like, the financial impact. And in traditional coding programs, you get a light introduction into payment reimbursement. That then in RHIA and RHIT programs, they have whole courses on reimbursement methodologies, but it's more broad. But in a CDI credential, it really, really drills down into how this how this documentation will directly affect the inpatient payment prospective system that is required for this person's admission. So one credential just won't guarantee success.
Thank you. Relevant experience is only gained in clinical settings.
No, because if you there you have nurses who, let's just say you have a nurse, and I have had nurses in my program who have done a specialty for 20 something years. So if you are in a specialty, you don't necessarily know med surg. You don't know all the conditions. Like, you don't, because when you're in a specialty, if somebody begins to decompensate, they take you off that unit and send you to the ICU. So you're so that type of acute care is not really addressed. So just one clinical setting, or even a couple clinical settings, will not prepare you. Like, what will prepare you for CDI, of course, is acute care, period, because there are certain standards that you should have experienced just in your nursing curriculum in general, mainly med surg. But if you work in specialties, and that's really why a lot of emphasis is put on critical care units like ICU, CCU, because they're very acute. But even though they're very acute, you still don't know, you still aren't exposed to all of the types of surgical procedures, all of the types of care, and all of the types of complications that can result. Like, if you are an ICU nurse, you don't necessarily know how to thoroughly interpret an op note. You don't know, if you read this note, oh, this person had had their liver lacerated. Now you're going to look for a drop in hemoglobin and hematocrit, or shortness of breath, or like discoloration, to show anemia. But you're not going to know how to code that. You're not going to know how to query the doctor for a complication, and if it is a complication, how that complication is going to affect the DRG. So clinical settings alone is not enough. It's a help and it can be a benefit, but it's only part of the knowledge you need to know to effectively do your job as CDI.
If you are interested in learning how to advance your nursing career by leveraging your nursing knowledge in a non-traditional role, enroll in our transition coaching program and download a free copy of our My Transition Journal today.
We want to hear from you. Schedule a free consultation or send us an email at advancednurses@acd4n.com or visit our websites www.advancednurses.info or www.acd4n.com.